myths. Didn't happen. Now, we know that the prevalence of ADHD in substance misuse disorder populations is about 23%. That's fairly recent research. A pretty good meta-analysis of the prevalence of ADHD in the general population, this is in adults, puts it at 2.5%. My own belief is that the prevalence of ADHD in adults is considerably higher than that, and it's probably exactly the same as it is in children, because I don't believe ADHD is a condition that goes away. I think people with ADHD, they develop, they learn strategies to manage their symptoms, or the condition is treated. 2014, Cronenberg and colleagues estimated that 1% of the population have both ADHD and substance misuse. That's quite a big problem. How many people are here today? I'm looking around, is it about 200? So 2 of you have got both ADHD and substance misuse. It's quite staggering, really. Actually, thinking about it, it's probably higher than that, because the people who are interested in ADHD generally have ADHD traits, so who knows? Yeah. So, what do we know about adults and adolescents and substance misuse? We know that we know that ADHD is associated with much earlier initiation and much higher rates of lifestyle and substance misuse in people with ADHD. And we're looking at these sorts of figures. Now, again, because I was a general psychiatrist in Birkenhead, these figures weren't really all that impressive, but when you look at it compared to the rates of substance misuse in the general population, they're considerably higher. So why are ADHD and substance misuse linked? Lots of explanations, lots of people have written about it. Impulsivity. Okay, people with ADHD are impulsive, they will take risks, they'll take substances. There's a lot of talk about whether ADHD people use substances as a form of self-medication, and I think there's a lot of truth in that. A fairly typical thing of people who I assess, when they come to see me in clinic, one of the questions I'll ask is what drugs have they used, what have they tried. I'll say, so you've used cocaine, how did that make you feel? Some people say cocaine's rubbish, it doesn't do anything. Some people say it puts them to sleep. Other people say it overstimulates them. A lot of people with ADHD find that cocaine has a very similar effect to Ritalin. To the extent that I'm just wondering whether, is Jackie still here? Jackie Gregg? Where? Oh, there you are. I just wondered whether you thought about asking the commissioners about having a line of cocaine for your patients to snort, because that would really speed up the pathway, wouldn't it? Anyway, the cocaine thing is a little bit of a myth, in the sense that people with ADHD don't all go to sleep when they take cocaine. Most of them have the typical response of being overstimulated, so don't be fooled by thinking that you can diagnose people with ADHD by giving them cocaine. But the rest of the substances of misuse, you've got your depressant drugs, you've got your stimulant drugs, they all work in different ways, but they have the final common result. They increase dopamine. They make you feel good. So there's lots of reasons why people with ADHD, they've got low self-esteem, they've failed at lots of things in their life, might want to self-medicate. Risks of ADHD and substance misuse have increased in people who've got a comorbid history of conduct disorder or bipolar disorder. So, what about the evidence for treating ADHD in adults who've got substance misuse problems? In adults, the evidence is extremely poor. Margan and Muller, that's a review article, really couldn't find much evidence to support treatment of ADHD in adults with active substance misuse. One of the things that we know about childhood is if you treat children with who've got ADHD with stimulant drugs, their risk of developing substance misuse problems is significantly reduced. And again, that busts a bit of a myth that if you're treating children with stimulants, maybe they all become stimulant addicts when they grow up. There's no evidence of that. The evidence is the reverse, that their rates of substance misuse are much reduced. Right. There are a number of obstacles in treating people with active substance misuse. The golden rule, you've got to treat the substance misuse first. And that's in nearly every aspect of psychiatry. So if you're an alcoholic, you can forget having treatment for your depression unless you give up your alcohol. And that just goes across everything in psychiatry. And if you actually look at the British Association of Psychopharmacology guidelines and also Stephen Stahl's books, they have this hierarchy of disorders in the order in which you should treat them. Right at the top, you should sort the substance misuse out first. And it goes down the hierarchy: substance misuse, psychosis, depression, anxiety, and right at the bottom of the list is ADHD. Now I ask you, how on earth do you expect a chaotic substance misuser to address his substance misuse if he or she have got ADHD, if they're impulsive, if they can't plan, they're chaotic, they're disorganised? They stand no chance. But we are rather stuck with guidelines, I'm afraid. I personally hate guidelines. And I try and resist using them. I like to use my common sense. I've been to medical school. I'm capable of independent thought. Therefore, I will use guidance, to help me when I'm stuck, but I'll make my own mind up. The other risk with treating people with active substance misuse is, what will they do with the drugs we give them? We could give them atomoxetine. Superb, it's got no abuse potential. The drawback is it takes a long time to work. And we're looking at chaotic substance misusers who want quick answers. The risk with Ritalin is that they will get diverted, they'll get abused. If you crush up methylphenidate and snort it, it is almost the same as snorting cocaine. So big obstacle. And then finally, there's cardiovascular risks. When we start people on treatment with methylphenidate or atomoxetine or dexamphetamine, we have to assess their cardiovascular risk. Why? It can increase your pulse rate a little bit. There's some evidence that it might increase your blood pressure over the longer term. There's absolutely no evidence that it's associated with risks in the long-term future of stroke, heart attacks, but the guidelines tell us that's the case. When you've got substance misusers, when you're hammering opiates, when you're hammering cocaine, then you really do increase your cardiovascular risks. So you're looking at adding another medication which will further complicate that. So there's a number of reasons why you shouldn't treat adults with substance misuse problems for their ADHD. Now, when I started this talk, do you remember I said I'm not the sort of person that listens to managers? I'm certainly not the sort of person that listens to guidelines. One of the great things about starting work in ADHD in the sort of late 2000s is the fact that there weren't many people around. So when I planned to do something, there wasn't really anybody who could challenge me. So I set up a pilot ADHD service within the Wirral Drug Service. I managed to get funding from this from an innovations project in the Northwest, and from June 2010 to 2011 I went to the Wirral Drug Service every Tuesday morning to do a clinic. The substance users, key workers, were all trained to recognise ADHD. They did a very brief screening questionnaire and asked a couple of questions about whether they had a previous diagnosis of ADHD or not. Following the diagnosis, we recorded a number of outcome measures, so impulsivity, attention, hyperactivity, self-esteem, sleep, drug use. Everybody had an ECG. Everybody was on a drug that could interfere with the heart. Mainly it was methadone. Some of them were really chaotic users, and all the ECGs came back completely normal. We treated them with Concerta in the main. Where that wasn't appropriate, we used atomoxetine. And what we did with the Concerta XL, to avoid it being diverted or sold or misused, the patients picked up their Concerta when they collected their daily methadone. We followed people up monthly to titrate the doses. So in total, over that period, we had 56 referrals. We managed to assess 50. 45 were diagnosed with ADHD, and they were all offered treatment. One of the things that completely amazed me, we're looking at a group of people who love drugs. 4 of them declined treatment. I was amazed at that. But I think it also goes to show that my normal ADHD practice, people are referred to me because they want treatment. In this clinic, the key workers were making the decision about whether they needed to see me or not. So they didn't really have the same choice that my normal population have. So 41 were treated. Before the treatment, of those 41 that were treated, 29 were dependent drug users and extremely chaotic. So they were on their methadone prescriptions and they were abusing other substances. They were always under threat of having their methadone withdrawn. And they, so they were really chaotic people. 11 of them were stable on their methadone, plus 2 who were on dexamphetamine, and we had 1 person who was already on the way to recovery. At 6-month follow-up, not bad this, we'd only lost 6 of the people to follow up. When I say lost, they were still alive and with us, but they just didn't attend for follow-up. The numbers who were chaotic had dropped down to 9. We'd got 5 who were abstinent. The 2-year outcome, the numbers dropped to 34. Again, nobody dead. 8 of them were now dependent and chaotic. So again, further progression, and 6 abstinent for all drugs. Now let's just make that, I hope you can read that, just to make it a little bit more clear. Those are the same figures just to show the dramatic reduction in drug misuse just by treating ADHD. The figures that I've put in brackets, these are the worst case scenarios. So in other words, of the ones who were missing from the follow-up, if we assumed they had stayed just as bad as they were to start with, the dependent and chaotic to start with, 29, had dropped to 15. But of course we couldn't follow up all those 15. But when you did statistical tests for all of them, they were all statistically significant. So in terms of the other outcomes, the global assessment of functioning had improved, inattention improved, hyperactivity, impulsivity improved, risks had reduced. This is risks to others. Really interesting thing in my population of people with ADHD, don't represent much of a risk to themselves, but they do represent a risk to others.